Morning, Elaine.
Hi, morning. How are you?
I'm very well. I'm wanting to go to sleep.
Please don't.
How are you keeping?
I'm doing well, thank you.
Wonderful.
Morning, Elaine. Good morning.
Julie, so nice to see you.
Thank you.
Hi, Auntie Elaine.
Hey, Charles. How you doing? How did you week?
I'm good, thanks. Right. So welcome, everyone. Good morning. For those of you who are joining us for the first time, welcome to the Health Hour of the Caribbean and African Health Network. This has been going on for probably just about 2 months or more now. Well, yeah, over 2 months. And basically, we thought it would be great to have our own Black health professionals on the front line doing amazing stuff to spare a bit of time, especially during COVID. But we're hoping post-COVID, we will still continue with, the health hour and even take it to radio stations and other places. So welcome, everyone. This morning, we're delighted to have Mr. Theophilus Asumu, who is a consultant. He's going to deal with all things bones, and help us, to understand some of the prevention message, some of the self-care. Because as an organization, we're really keen that, as much as we engage with policymakers, we need to be encouraging our community around, self-care, self-management, and what we can do to help one another. So I'm just going to encourage everyone to mute your mics since you're not talking. In the course, this is being live streamed on YouTube. It will become a resource that we have on our YouTube channel, but also we will share the link with others. There's a chat box for you to ask your questions. You can also send me private questions, during the course of the event. So, I'm going to hand over to Mr. Asumu to introduce himself, and he has a PowerPoint presentation. So over to you, Doc.
Thank you very much, Charles. Thanks for giving me the opportunity to address this platform via the Caribbean and African Health Network and tell you a little bit about what I do as a consultant in orthopedic surgery. I understand the format is I'm going to speak on things relating to orthopedics for about 20 minutes, which will give ample time for people to come back with any questions. What I would say is that what I will talk about in 20 minutes will just scratch the surface of orthopedic surgery, but please feel free to ask questions either related to the presentation or indeed not related to the presentation. I'm happy to take things outside those areas, but for the sake of brevity, I'll keep it down to about 20 minutes. I have a presentation which I am going to now attempt to share, and we know the foibles of technology, but my daughter has given me very good instructions on what to do, and hopefully we will be able to so Charles, can you just tell me if I'm on screen? Can you see my screen, my slides?
Yes, indeed, we can see you. Great.
Okay, that's fine. So
you took the lesson very well.
Yeah, she will please. So I'm going to give a brief overview of trauma and orthopedic surgery. I'm a consultant orthopedic surgeon. I'm based in the northeast sector of Manchester. My base hospitals are largely Fairfield Hospital and North Manchester General Hospital, but I also work a little bit in the Royal Oldham and Rochdale Infirmary. By means of background, I trained and qualified in Nigeria prior to coming to the UK for my postgraduate training, which I did the vast majority of in the Manchester region, where I have been since. So what I'm going to do over the next 20 minutes or so is just give an overview of what trauma and orthopedic surgery is about. I will give you some case examples, and the case examples are hypothetical. They're not real patient scenarios, but they could be patients who present. And Charles has asked me to speak on osteoporosis, and I'll do that from the viewpoint of an orthopedic surgeon. And there will be time for questions and answers at the end of the presentation. Now, in terms of the scope of trauma and orthopedic surgery, it is all things bones and joints, and so it's the parts of your skeleton that you generally recognize as moving: your arms, your legs, your back, your neck. The bones and joints in those parts of the body, as well as the muscles, ligaments, tendons, cartilages around them, that make up your the bulk of your musculoskeletal system. So that's what we tend to deal with. Two groups of patients present to an orthopedic surgeon. You've got those who come with pain, and those are generally referred to by the general practitioner. So I'm talking about a UK practice now. So patients who develop pain in, knee, hip, ankle, shoulder, etc., would go to their general practitioner, and when they feel they need a specialist opinion, they would get sent to an orthopedic surgeon. The other group of patients we see are those who've had injuries. And so if you've had a fall, a car accident, etc., and the vast majority of this comes through the emergency department. And having had your primary treatment in the emergency department, you may then be referred to see an orthopedic surgeon. I will give you a few case examples of who I might see. So, hypothetical 24-year-old male who works in a warehouse, and he enjoys playing five-a-side football at the weekend. So last week he's been playing football, he's been tackled, and his knee doesn't feel right after the tackle, but he continued playing, but he moved to goal. He wasn't playing in the outfield for about 15 minutes. And ever since, he's been limping. His knee is swollen, and he finds he's not able to work because of the knee. And this is quite common. If he will likely go to an emergency department where he will almost certainly have an X-ray done, which will almost certainly show that there is no fracture, no broken bone in the knee. And then he'll be sent home to recover. Now, the majority of these acute knee injuries they're generally non-specific, and it is difficult to tell you exactly what's going on initially, because the X-rays are largely normal, and it's the softer parts of the knee, the ligaments, the cartilages, that we're concerned about. Most of the time, it's just a non-specific bruise to the knee, and they respond to measures we call RICE, which is an acronym for rest, ice, compression, and elevation. So the treatment in this case will be to provide the patient with a pair of crutches, perhaps access to physiotherapy or rehabilitation exercises, advice to rest, apply ice to the knee, and not directly on the knee, but you need something between the ice and the skin, so maybe a towel. And you need to put the ice on for 15 to 20 minutes at a time. Do that 2 to 3 times a day. And as much as possible, keep the limb elevated. Things get better over time. And over a period of 6 weeks, we'd expect that patient to be back to normal activity. If there are ongoing problems, or the knee improves, and then you have further problems, and it swells up and gets painful for no evident reason, we would, at this stage, want to look a little bit closer. Knowing that X-rays are normal, the investigation of choice here would be an MRI scan. And that will show us whether you've had a damage to a cartilage or one of the major ligaments in the knee that can get injured is the anterior cruciate ligament, the cruciate ligament injury. Now, for those of you who follow the English Premier League, you have probably been aware of people who've had cruciate ligament injuries. And they are serious injuries. They are career-threatening because they don't leave you with a functional knee that allows you to play high-level sports. But reconstructive surgery can salvage a career. So Alan Shearer has had a successful cruciate ligament reconstruction and then went back to score at the highest level, as has Roy Keane, Paul Gascoigne, Ruud van Nistelrooy, and Michael Owen, just a few who've played in the Premier League at the highest level after having fairly major reconstructive knee surgery.
Switch now.
Another case example is a 58-year-old man who works as a delivery driver for Amazon. Over the weekend, he went up into the loft and he did a lot of DIY. And he spent a lot of time squatting in confined spaces, moving around, and his knee felt a little bit achy afterwards. The following day became very painful. And he also noticed his knee was swollen, he's limping, he's not able to work. And this is something I see quite often. And what's happened here is that he's had a tear to one of the meniscus in his knee, a degenerate meniscal tear. And it's quite common in people who are over the age of 50, who have some arthritis but are not aware about it. And they come in with a bit of pain. If you look at what is the left knee in this patient, but it's on the right-hand side of the picture, you will notice that there's some swelling around the knee. So they don't give a story of having had any trauma, not like the footballer we just spoke about, but they tell you that they were squatting for a while, or there was a twisting incident to the knee, getting out of a car awkwardly, stepped off a pavement awkwardly. But they can definitely tell you when it started. Treatment for this it can be difficult. In the first instances, we would use the same measures of rest, application of ice, compression, and elevation. And the vast majority will settle with those measures. For those who don't settle, they probably need surgical treatment in the form of a keyhole exploration of the knee and arthroscopy, which will be done under a major anesthetic. And that allows us to identify where the tear is in the cartilage, take it out, and allow the patient get back to normal activity. But it is a marker that the knee is somewhat degenerating. That they probably need. So it's an indication that the knee is somewhat degenerate, and there is the likelihood that you will continue to get problems with it in the fullness of time. I'll move on to another case, a slightly older lady who is 62. She's a shop assistant, and she's a very keen runner. She hasn't been able to run for a while now because in the last 2 years, she's had pain in the knee, which worsens when she does any activity. She continues to work, but she's starting to depend more and more on painkillers and is getting it with the weekly shopping. Now, for anybody who has pain and stiffness in the knee after the age of 50, the diagnosis is arthritis until someone proves otherwise. So that's a fairly safe supposition to make. On the left-hand side of the screen, there's an X-ray of a normal knee where you can see some space in between the bones of the femur on top and the tibia below. And on the right-hand side of the screen, there's an X-ray of a patient who has arthritis of the knee, where you can see that on the left half of the X-ray, the bones are pretty much touching each other as compared to the right half. And that's what happens with arthritis. You get wear and tear of the joint surfaces, and you get bone-on-bone contact, which is quite painful. Arthritis is very, 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 very common. it's very, very common. And hip and knee arthritis are some of the commonest conditions we treat. Major knee replacement procedures are probably the commonest orthopedic major operation we're doing in the UK today. So for people who have arthritis, only a small percentage require any operations, but there are things you can do for yourself. Weight loss is good because it takes pressure off the weight-bearing joints. And if you're overweight, you should try to lose weight. But at the age that arthritis starts to set in, it is difficult to lose weight because that's done by a combination of diet and exercise. And exercise is very difficult in that age group. You should certainly be avoiding impact activity. So things like running, no matter how much you enjoy running, once you start to get arthritis in the knee, if you continue running on the road, that will worsen at a quicker rate. Non-impact activity like swimming, like cycling. There are some machines you can use in the gym which don't involve impact activity. That is good because it helps you burn calories and maintains your muscles without putting impact on your joints. Physiotherapy is also quite good. They will teach you exercises to maintain your muscle tone and to maintain the range of movement in the knee. And there other things like using a walking stick. Certain patterns of arthritis, you can use a knee support or a brace, which will be advised either by the doctor or by a specialist physiotherapist. In terms of medication, painkillers are the mainstay of the treatment for arthritic conditions. And people usually start off with things like paracetamol and ibuprofen. But these should only really be taken on advice of your general practitioner to avoid a situation where you develop side effects or you take medication which you don't find effective. When these medicines no longer work, as often is the case as the arthritis becomes more severe, there's the place of injections into the knee of a variety, commonly steroid injections, which have been halted for a while over the last 3 months because of COVID. And we can talk a little bit about that. And for patients who really don't improve despite all measures, then we consider surgery. The two main types of surgery we would carry out are either a keyhole operation, which is the image on top, which cleans out any debris from the knee, takes out torn cartilage, removes loose bodies, or replacing the surfaces of the knee with metal and plastic. And those are the images below of a patient who's had a knee replacement. Knee replacement is a major operation. You will have a major anesthetic. You'll be checked out by the anesthetist beforehand. You will have a pre-op assessment. The operation lasts about an hour and a half. And you usually are out of hospital after about a day or two, depending on how fit you are. I won't lie to you, it's painful afterwards and remains so for about 4 to 6 weeks. And then things start to improve. After 3 months, you're pretty much where you want to be. And you're back to your previous mobility with or without a walking stick. But that nagging pain of arthritis is gone. And it is transformational surgery, as is hip replacement surgery. I want to give you an example of the other end of people who I see, and those are those who have an injury and they're brought in through the emergency department. So we have a typical case of someone in their 70s, female, retired, who's fallen at home, has pain in the hip and cannot walk. And in that case, usually you would call for help and the emergency services, the ambulance will attend and you'd be taken into hospital. This lady had a fracture of the hip. The image with the green arrow shows where the fracture is in the hip. And the treatment for fractures of the hip always involve an operation. they always involve an operation unless the patient is so frail that they would not withstand an operation. And that's only in about 1 to 2% of cases nationally within the UK. And so in this particular case, the treatment was to remove the broken part of the hip and replace it with half of a hip replacement, which is the image you can see with the metal implant in place. There are other methods of treating fractures of the hip, such as using metal pins to hold the fracture together. This is a different fracture pattern, and this has been treated with something we call an intramedullary nail. It's just one of the implant devices we use to hold the bones together. In this, we expect the bones to knit together in the fullness of time, which is why we've chosen that implant. Now, the reason the lady in her 70s got a fracture of the hip from a fall is because she almost certainly has osteoporosis. And osteoporosis refers to bones becoming brittle. The image I'm showing shows a cross-section of the hip bone, and they're just various cross-sections. These are not actual hip bones, they are just models. But from the left to the right-hand side, you can see that the bones are getting less dense, and they're becoming more brittle, and so they fracture more easily. This is almost an inevitable aging process. And once your bones start to age, then your bones start to get thinner. And beyond the certain threshold, which we call the fracture threshold, it becomes very easy for you to sustain a fracture from a simple fall. So what do we know about osteoporosis? There are certain things that make you prone to osteoporosis. The most important is age. The older you are, the more likely you are to have osteoporosis. And so what the graph shows here is what happens to your total bone mass through your life cycle. And your bone mass increases very quickly, up until the age of about 20. And somewhere between 20 and 30, you reach your maximum bone mass, and that's it. Your bones have stopped growing and have stopped putting any new calcium onto the bones. And from then on, your bones start to become less dense and more brittle. Now, men tend to have a higher bone mass at the peak than women, and that's just the difference in the hormonal composition of men and women. And so women start from a lower maximum bone density and then start to decrease from there. And after a certain level, you hit an area where we tell you, well, you've got osteoporosis now. So one of the things you can do to prevent osteoporosis is to ensure that whilst you are in your formative years, before the age of 30, your diet is adequate and you have satisfactory vitamin D. And in terms of diet, the important thing is dietary calcium. Vitamin D is difficult to make adequately in climates like we are in Northern Europe, especially in Manchester, because of the lack of adequate sunlight. So over-the-counter vitamin supplements are generally advised. So the older you are, the more likely you are to have osteoporosis. And like I said, women don't get to as high peak bone mass, and so they become osteoporotic quicker than men do. The other important factor with women, and I think this was touched on last week by the gynecologist who was speaking, is menopause, which happens at about the age of 50, 51. And the lack of estrogen accelerates the loss of bone mass after menopause. And so postmenopausal women are particularly at risk of osteoporosis. Now, when your bone density goes below a certain level, you hit something called the fracture threshold, and that's where you start running into problems with low energy fractures. So these are figures which relate to the UK, and we call it the pyramid of osteoporosis. So osteoporosis has no symptoms at all. You don't know you have osteoporosis because your bones just get brittle. And until something happens, you really can't tell you have osteoporosis. So we see about 300,000 new fractures every year, and that's the tip that presents to us. Under that, you've got about 1.3 million women who already have had fractures and they have osteoporosis. And that's what we know about. What we don't know about is the 3 million plus women who are postmenopausal and have osteoporosis. And that's the target group that really you want to see if you can prevent them getting a first fracture. Having had a first fracture, it's usually easy to try to prevent a second fracture because at least the condition has now presented itself. But the 10 million odd women who are postmenopausal in the UK and the 3 million odd women with osteoporosis have no symptoms, and it's a silent disease. So coming back to the lady who had the hip fracture, it's quite common in the UK and the incidence is rising. It's about 1 in every 1,000 population. So we see about 60,000, 70,000 hip fractures every year nationally. And I've just put two population pyramids side by side. The one on the left is a more typical population pyramid, which is one from Nigeria 2020 estimated, where it looks like a pyramid. The vast majority of people are under 30, and as you go up, the attrition rate is quite high. On the right, you have the UK population distribution estimated 2020. And because of the lack of infectious diseases, problems with malnutrition, etc., there are no real excess deaths below the age of 60. It maintains itself. And so we have an aging population. And this is the reason why we're seeing so many hip fractures nowadays as a result of osteoporosis. And this graph just shows you what happens to who gets hip fractures. And it's people really who are above the age of 65, 70, mainly women. 80% of the hip fractures we see are in women. Hip fractures, in addition to being common, are also very expensive. And they're costing currently about £2 billion a year. And that's in terms of the hospital admission, rehabilitation. At times, the recovery isn't quite as good. And so people might need rehousing because they can't cope with stairs or independent living. And it's certainly a problem in terms of quality of life after a hip fracture. And most, if not every patient, will tell you that. When patients recover from hip fractures, they end up with a decline in their mobility, most of them. And patients who are independent would maybe need one stick, and if you walk with one stick, you may need two walking sticks or a Zimmer frame, or just be limited to bed to chair transfers. So it's quite something to deal with at that age in life. There's also a significant mortality associated with hip fractures, and I've always described it as being as serious as cancer. When we look at hip fractures, so when we look at cancer survivorship, I'll just digress a minute. We have something called a 5-year survivorship. So if you survive cancer 5 years, many people think, well, I've been given the all clear. So what percentage of people survive cancer for 5 years? Skin cancer, 90%, breast cancer, 85%, cancer of the prostate, 65%. Hip fractures, 55% will survive 5 years. So it's very serious. The survivorship it's only things like lung cancer, which is a killer, that are actually more deadly than a hip fracture. So it's something which if possible, we can try to address by the background problem, which is osteoporosis. this is my last slide. I'll just leave you with these two statements to think about. That the strongest predictor of having a second or a future osteoporotic fracture is if you already have one. So if you've had one osteoporotic fracture, and the first is usually, the common sites are at the wrist, at the hip, and in the spine. So usually we see people with a wrist fracture, and a few years later they end up with a hip fracture. So it's something to think about, and it's something GPs are very aware of. And the second is one from our specialty association, which says to orthopedic surgeons that our response to an osteoporotic fracture must include a determined attempt to prevent another one in the future. And this is something which I think should be at the forefront of all our minds. If we or any of our loved ones, especially females over the age of 50, has a fracture. So I couldn't leave this without acknowledging the work the NHS has done, not just in the last few months, but certainly ever since I started working in the NHS. And I think it's truly, truly a marvelous organization. I've worked in other health systems in the Middle East, in Africa. I've got knowledge of systems in America, and I don't think anyone comes close. So that's my presentation done. And
Right. Thanks for that, Doc. Lots of questions for you. We're going to kick off. So please, if you've got any questions, you can put it in the chat box, or you can send them privately to me, via the chat box as well, but we will crack on. So questions from Tiffany. What is the best type of surgery for subluxation of the knee? I have severe ones on both knees, and x-rays have revealed kneecaps are slightly smaller than the average kneecaps. And then the second one is, how bad will the scar be after the surgery, as I'm terrified of bad scarring?
Yeah, so subluxation of the, I'm presuming this is subluxation of the kneecaps, and that is a problem. So the kneecap unpredictably slips out of position.
Correct.
It depends on the age at which this is happening. Common age of onset. Sorry.
Okay, I'm just going to answer your question as you ask. I've had it since I was a child. My sister and I'm 30 right now. Okay. So we've sort of gone through our 20s, walking very cautiously. We don't wear high heels.
Yeah.
And once it happens, the twisting of the knee, it's so painful. It's the worst pain. Yeah. And maybe I would say it happens once every 2 years, once every 3 years, because we are just so careful, walking in flats, walking very slowly, and we are ready to perhaps have a surgery or whatever, because we know it's going to get worse as we get older. But I'm 30 and my sister is 28.
Okay, so the story you give is fairly typical in that it starts usually in teenage, and usually there's a definite type of injury. People think it's a definite injury when it starts, but it's probably a predisposition that has been there. So the bottom of the thigh bone is maybe not quite as deep as it should be to contain the kneecap in it, and it's a little bit shallower. Now, what is required is an assessment of the internal anatomy of the knee with an MRI scan. And that will look at three things. It will look at the shape of the socket of the kneecap, which is the front of the thigh bone. And usually it will show that instead of a valley, it's flatter. And that's allowing the kneecap to escape.
Yes, that's correct,
yes.
Yeah.
It may also show that your kneecap, which is supposed to be sitting maybe here, is sitting higher than it should be. And that's because the tendon is longer. And that allows it's a bit like a windscreen wiper.
Yes, exactly. Yep.
Yeah. And so depending on the abnormalities that show up on the scan, you would require for maybe the kneecap to be brought down by a bone transfer just under the kneecap, on the front of the shin bone, or for the the groove where the kneecap sits to be deepened, a procedure called a trochleoplasty. And if your kneecap is under an excessive lateral strain, it may also need a transfer to bring it more in line. The reason why so if you were in your late teens, early 20s, that would almost certainly be what would be required, a stabilization procedure. If it's happened over a long time, another thing that's taken into consideration is whether you're starting to get early wear and tear on the cartilage of the kneecap. That introduces a slight level of complexity, and you should ask this, because if you're starting to get wear and tear, then stabilizing it could increase the pressure and cause pain. So it's something to be aware about when if you're around the age of 30 or 35. Scars depend on what's going to happen. The scars for taking a tendon graft is taken from the inner side of the knee and one of the hamstring tendons, and it's probably about a couple of centimeters to harvest that graft. And that's put on the inner side of the kneecap. So the scars are not a big problem. If you have to have your groove deepened, you do get a bigger scar, unfortunately.
Oh dear. But what about just a standard knee replacement surgery? Can't that just solve everything? Because you're getting a new knee, from my understanding, right? What about that?
Yeah, a knee replacement will solve the problem of your kneecap dislocating. But at 30, we would have to have a lot of discussion before we went down the roads of knee replacements. What we know about knee replacements is that they don't last forever. They are made of metal and plastic. So if I may show you one here, this is what a knee replacement looks like. So that's the bit of plastic that will be acting as your new joint.
Okay.
And over time, that would wear because of your age and your activity levels. So don't forget, the average person who gets a knee replacement is about 65, 70, and the activity levels are much, much lower than yours. They don't have an active lifestyle. They don't have young children to look after. They're most likely not working full time. And so the number of steps they take a year is significantly less. And we do see much higher wear patterns for patients who have, patients under the age of 50 have significantly higher wear patterns. We know that people who have a knee replacement, 9 out of 10 of them are still happy after 10 years. And after 15 years, 8 out of 10 are still happy. But that's in the age group who had it above the age of 60, 65. And people who have it at about your age, you'd be stretching it beyond 7 years. Then you have to have an exchange knee replacement, a revision knee replacement, and the results from that are not that good. So subluxation of the kneecap does predispose you to requiring a knee replacement in the long term. In the short to medium term, in discussion with your surgeon, the emphasis should be to maintain your own knee and get the kneecap stabilized. That would be my preference. Does that answer your question?
Yes, thank you so much. Yes, so I'll look into that. Thank you.
Thanks, Doc. Yeah, so another question for you. How has COVID-19 affected, your procedures? Yes,
COVID-19 has affected our procedures in a very big way. So emphasis is now on safety. Emphasis is on safety in terms of avoiding spread of COVID-19, patient to patient, staff to patient, patient to staff. So the first thing we had to do in preparation for COVID-19, based on the Italian experience, was to pretty much empty the hospitals. And I think many of you might have had routine appointments canceled, or, so people who were being referred with pain, we couldn't see them anymore. And we stopped a lot of routine operating. In fact, there was a national directive that non-emergency surgery would stop on I think the 15th of April. But we've continued to treat emergencies and fractures. So that stream of work has continued. what we have found is that if you do have major surgery, and there are a few studies which confirm this now, if you do have major surgery in the middle of a COVID pandemic and you get COVID-19 whilst recovering, the mortality rate is very high. So we're still proceeding very carefully. We have started routine operating now, non-emergency operating. And we're asking most people to ensure that they're not carrying coronavirus at the time they attend hospital, to self-isolate for 2 weeks before surgery. And so there's a lot of enhanced personal protective equipment we have to use in the operating theater, especially if a patient has a general anesthetic with a tube down an endotracheal tube down the throat, because if the patient is carrying COVID and is asymptomatic, you can imagine that there's a significant risk to all the operating theater personnel. So that's just a few of the changes that have been enforced on us by COVID-19.
Okay, thanks, Doc. Are there any, obviously we there's a Black forum. Are there any racial differences in bone density for Black people, that you've seen more likely to impact on particular, conditions?
Oh yeah. Thank you for bringing that up. On my slide, I talked about age, gender, and ethnicity, and I talked about age and gender and totally forgot ethnicity. But it's well established that Blacks have denser bones than Caucasians, so they're less prone to osteoporosis. And this has been validated in multiple studies in America and in the UK as well. And the people who seem to have the lowest bone density are people of Asian descent. But Blacks have much higher bone density. And so we tend to see less osteoporotic fractures in the Black population. Now, there's always been a query in my mind as to whether we see less fractures because there's truly less osteoporosis, or maybe, then this is just from my personal observation, there also appears to be a migration pattern whereby when people retire, they often find the climates, especially the winters here, maybe not as hospitable, and might decide to retire to a tropical climate in the West Indies or in Africa. And so we don't have that bulk of elderly people who are Black. But very correct, bone density in Blacks is higher than it is in Caucasians.
Thank you. The next question, how can a first and second fracture be prevented?
So I will deal with the prevention of the second fracture. We have a target range of patients who, when they present to us with a fracture, we ask ourselves, could this be osteoporosis? Not could this be osteoporosis? And that's anyone above 50. We just have that cutoff. Anyone above 50, we say, could this be osteoporosis? Then we look at the mechanism of injury. If you've been injured in a bad tackle or it's been in a high speed motor crash, then we understand that. If it's a fall from a standing height and it affects certain areas, that's the wrist fracture, a hip fracture, or a fracture of the vertebra, which is just a crush. Then we institute a host of measures. And the only way to diagnose osteoporosis is by bone density scan. And so those patients will be offered a bone density scan. And if they're shown to have osteoporosis, there are treatments which will decrease the rate at which bone density drops. They're called anti-resorptive drugs. Usually you take them by mouth once a week, in addition to vitamin D and calcium. Vitamin D and calcium is the bedrock of everything. You need that to make your bones work properly. But apart from those anti-resorptives, there are a whole host of other medicines. And we've talked about the link of osteoporosis to the menopause. And so perhaps people have had a premature menopause. Maybe they had surgery for some condition and their ovaries were taken out when they were 40. They have a surgically induced menopause. And perhaps for them, the best treatment would be hormone replacement therapy. And so there's a whole host of treatments for secondary prevention. For primary prevention, it's usually in the hands of the general practitioner because there are no symptoms and you haven't had a fracture. So we think, are you at risk? Has your mother had a fracture? Has your mother had osteoporosis? And that is something to consider. If your mother has had osteoporosis, if your body mass index is very low, if your BMI is below 19, then you're at risk over the age of 40. If you've been on steroids for a long time, so maybe people who have rheumatoid arthritis or who have obstructive airway disease and who are on long-term steroids, they should intermittently be screened for osteoporosis by the general practitioner. And if osteoporosis is detected, then appropriate treatment is started. Does that answer the question? If there are any comebacks on that, I will take.
So please, when I ask you a question and Doc explains and you have a follow-on question or a comeback, please let us know. The next one is, what is the best way to reduce pain when having Osgood-Schlatter disease during growth spurts?
So Osgood-Schlatter disease is pain at the top of the shin bone. There's a prominence at the top of the shin bone, which is where one of the major muscles inserts. So if you put your hand on your kneecap and then just drop it down about 3 or 4 inches, you come to a bony prominence. And what happens in children who are still growing is that the bone that the tendon attaches to isn't fused to the rest of the leg bone, and so it's possible to slightly pull it off. And this happens when you have a mismatch between the muscle strength and the bone strength. There's nothing you can do about the strength of the bones in a 14-year-old because they are what they are. But if the muscles are working excessively, playing a lot of football, doing a lot of running, you could start getting problems with Osgood-Schlatter's disease. The first thing we advise is activity modification. And this is heartbreaking to many of the patients and to their parents because this is someone who loves his football. This is someone who loves his cross country. But we have to say, you take it right down and you stop that continuous repeated traction injuries to the bone at the front of the tibia. That should settle down most of the cases, and then you can return to activity under the guidance of physiotherapists. In some people, it doesn't, in which case you have to go for stricter immobilization, and that's where you maybe use splints. That's uncommon to do now. And Osgood-Schlatter's anyway will burn itself out when you stop growing because your bones will fuse. And the bones fuse on the average at the age of 16 in boys on average, and about 14 in girls. What it will do if you've had a severe period of Osgood-Schlatter's disease, it leaves you with these knobbly bone prominences, which are not painful by and large, but make it uncomfortable to kneel on just because of where they are. So the first thing is activity modification, unfortunately. But it does allow many of those children to return back to sporting activity even before they've finished their growth. So it doesn't necessarily stop a sporting career, but it could have some implications.
Thanks, Doc. Another one from a 62-year-old Nigerian female, bone thinning on the left hip, and this has become painful during COVID-19. Any advice?
Bone thinning on the left hip. Is there any further information on that? Bone thinning on one side is unusual, especially in somebody who's in their 60s. Any further information? Has there been an injury in that area? Has there been infection? Has there been anything in childhood?
Bill, do you want to respond? Someone with the gadget, Bill's iPhone, Bill Isaacs. Could you unmute yourself and right?
So there's a host of
No fracture. There hasn't been any fracture.
Okay. So the bone thinning, how was that diagnosed? And I'm especially interested in how it was diagnosed on just one side.
Honestly, I cannot remember. Let me be honest.
Okay.
But I know that I had to have some DEXA scan.
Okay.
And now I can't remember the genesis, but I
Okay.
know I now have to do them every either 3 or 4 years. And
Okay.
I was told it wasn't getting any better.
Okay. So a DEXA scan will diagnose osteoporosis, and by and large, osteoporosis isn't painful. So I will be looking for other ways of getting imaging of that hip.
Okay.
I would presume by the time you've had a DEXA scan, you would have had a plain X-ray. That's just a standard X-ray. If that X-ray hasn't shown anything, in 60s, I'll be looking for arthritis, and there are some forms of arthritis that can be rapidly progressive. So if you have 2 X-rays 6 months apart, it's very instructive. Or an MRI scan. There is a condition which is uncommon in people in their 60s. It's probably more common 20 years earlier, which is called transient osteoporosis of the hip. That is, it just happens for a brief period of time, about 3 to 6 months, and then gets back to normal. And we diagnose that usually on an MRI scan and advise protected weight bearing with crutches whilst the bone density gets back up to normal strength. But I would actually probably want a little bit more information. And Charles, I'm happy for you to pass my details across.
Okay, all right. So Bill, send the one who's just asked a question, send me a private message either with your number or details, and then we'll pick it up from there. Thanks for the offer. With hip fracture, can it start to be painful? I have arthritis in my back and possibly in my hip. How can I prevent a fracture?
So well, the only way to prevent a fracture in osteoporosis is really to prevent a fall. Good news, if there is any good news, is that people who have arthritis of the hip are very unlikely to have a low energy fracture. So osteoporosis and osteoarthritis don't often coexist. We very rarely see them. We do see them, but it is uncommon. And what tends to happen with arthritis is that the bone wears down and starts to become a little bit more dense, almost as if it's polished. And so people who have higher bone densities are more prone to developing arthritis, and we don't see them in the same population. So those people having hip replacements for arthritis are very distinct from those people who are having partial or total hip replacements for fractures. If you want to decrease your risk of a hip fracture because you want to decrease your osteoporosis, first of all, I'd advise, if you live in the UK, you should have vitamin D supplementation, and you can get one from Tesco as the multivitamin shelf in those supermarkets. No specific branding, just go for one that contains the recommended daily allowance of vitamin D. Your diet as well, dietary calcium intake should be adequate. Weight-bearing activity is quite important. So you should try to, most of us have a mobile phone, which we carry around, which probably has a step counter. You might want to set yourself a target of a number of steps to achieve every day, especially as we're in these lockdown periods where our activity might be a little bit lower. So those are the steps I would advise. For people who do have osteoporosis, if you're concerned, or if you've got a relative and you're concerned about them, I think one simple thing to do is to look around the house and see if there are trip hazards. Are there carpets that are lifted up? Is the lighting okay? Are there cables that are trailing from extensions, etc.? Because that's how the fractures happen. It's a fall in the hole.
Thank you very much. I appreciate that. Thank you.
Right. So we have Sherry. Do you want to unmute yourself and ask your question?
Hello, doctor. Good morning.
Good morning.
I was just wondering if not liking milk or dairy products is detrimental to bone health, which is the first part of the question. And could it have been a factor into a fixed deformity that I have in my middle finger that has made it arthritic as a result?
So I'll take the second part first. A fixed deformity localized to the middle finger wouldn't be related to your calcium intake. If you don't like milk and dairy products, you get less calcium, but you can make up with other calcium-containing foods in your diet. Don't forget that the pattern of milk consumption that happens in most of Western Europe and North America is very different from that in many other parts of the world where, you know, drinking a glass of fresh milk really is not done. For instance, I spent my entire childhood in Nigeria never drinking a glass of fresh milk because it's just not something we do. But it is a good source of calcium. But not drinking milk isn't particularly hazardous if your diet is otherwise balanced. It is important to have an adequate intake of calcium during your growing years, up to the age of 20. That's when you're building up your bone mass, and you build up to a peak, and from then on, really, it's everybody declines. It's like graying of hair. It's aging of the bone. So it's important to maintain your calcium intake. About the fixed deformity of your finger, which finger is it?
The middle one.
The middle one. Do you mind my asking, is it something that's happened all of a sudden, or is it something that has been there for a long time?
Doctor, it literally happened overnight.
Okay. Once again, Charles, I'm happy for my details to be passed over, because if it's happened suddenly, then it can be addressed. And there is something that's happened and it's not due to calcium, and I'm happy to have a chat with you.
Thank you.
Thank you, doctor.
So
You're
Sherry,
welcome.
if you can drop me your details privately, I will pass that on. And you know, we're grateful for Doc and the others who give time, you know, free private consultation. It can't get better. You know, they are amazing heroes in our community. Right. Doc, can you comment on this? You know, you answered that earlier on. I forgot to mention my consultant said I already have wear and tear on my lower back, and there's nothing else that could be done except pain relief and gentle exercise.
Yeah, back problems are difficult, and we're lucky we work with with the knee and the hip, and that's just one ball and socket joint. But at every level in the vertebra, there are about 7 joints, and you've got 5 lumbar vertebrae, 12 thoracic. So you can imagine how many joints there are. And when you have wear and tear in the back, we've struggled with this for a long time, and there isn't a good solution. At one stage, we thought it was because the discs were worn and people designed disc replacements. They are not particularly successful. There are still few people who offer disc replacements. There was a time when if you had an arthritic joint and it made sense, if movement was painful, then you stiffened it and you stopped it moving. And you can still do that in some joints. And at the back, spinal fusion, fusing parts of the back, was done for back pain. But it seemed to just transfer the pain to the next level. And so most of the treatments for back pain, which don't cause trapping of the nerves and pain going down the leg, is by self-help methods. It's physiotherapy, rehabilitation, and exercises. There is a place for pain relieving injections, acupuncture, Sometimes a targeted epidural by the pain clinic doctors will help. But these are just measures for pain relief, and they are temporary, and they do tend to come back. So I think the best thing would be to have somebody beside you, almost as a coach, who would help you with, daily exercises, muscle strengthening exercises, posture. In terms of surgery, the surgical results from for back pain haven't been as impressive as we would have hoped in the face of arthritis, certainly nowhere near hip arthritis or knee arthritis.
Thank you very much. I appreciate that. Thank you. And yes, you were quite right. I had the epidural that didn't work. It came back again. I had the acupuncture that didn't work. It also came back again. But I'll just continue to do my exercises, and I'll think about getting somebody to work alongside a specialist or somebody in a gym. Thank you. I appreciate it. Thank you, Doctor.
You're welcome.
Thanks. The other question, we have lots of questions, and maybe we need to have you back next week if you're not on call. But sorry to put you on the spot. My son had an injury playing football. His hamstring is now non-existent. How can this affect him later in life? He's 25 years.
If the caller is on the line, I would like to know, the hamstring has two attachments. So there's one attachment around the buttock and there's one around the knee. And it depends on where the hamstring came off and how long ago. If that information is available, I will start talking about both of them anyway, whilst we try and get the caller on.
So, yes, my son played football from the age of about 9. He played it professionally.
Yes.
Out that his hamstring has gone. It is virtually non-existent. So, and we found this out through an X-ray. So
did the hamstring go from the top end, that is around the buttock, or from the bottom end, which is around the knee? Do you know?
It's about the top half.
Ah, right. Okay. Right. Okay. Yes. So the that injury is usually the result of an explosive action, sudden change in direction or sudden change in speed. And football is a classic one. You're setting off suddenly. And similar to what I talked about in Osteoporosis, you have the muscle pretty much is stronger than the bone it's attached to, so it pulls it off. It's something which to be honest, we're still recognizing and learning more about this injury as we speak, because there's still division amongst the sports medicine physicians and other doctors, whether or not an immediate repair. But people are tending now more towards an immediate repair of that injury if it's recognized. The hamstrings tend to in the long term be okay. Without surgery, without surgical reconstruction. It could make a difference if you're at the very, very, very top end of performance. And so for people like myself who just, walk up and downstairs, go to the hospital and back, I could have a hamstring injury, and when it resolves, I would know nothing at all. If I was depending on, if I was a county level sprinter, or if I was, playing semi-pro professional football, then there'll be an impact of that on my game. And it is one of those injuries that if it's happened a while back, what happens with muscles, they do tend to retract, almost like a washing line that's been snapped at one end. It does tend to retract and stick to the muscles around it. So if it's happened a while back, then it is rehabilitative physiotherapy and ensuring that the hip and the knee, because the hamstrings cross both joints, retain full movement. And for the hip is to make sure that the flexion isn't affected, because that's what the way the hamstrings tend to scar. And for the knee, extension. Can I ask if he's still playing football, or has he had to give it up?
He's just recently stopped playing.
Okay, and that's from choice. He no longer wants to do it.
I think he feels it's better if he doesn't.
Okay. So I mean, if he's not going to participate in high-end competitive sports, to be honest, he'll be okay. There won't be any long-term issues. It could affect performance at high level, but if he's going to, end up as sedentary as me or most people, I'm not particularly sedentary, but I'm not competitive. If he's not going to be competitive, he should be okay.
Thank you.
So, Doc, are you available next Saturday? Because we've got loads of questions in the chat box.
Yeah, I'm available next Saturday.
Right. So if it's okay with everyone, next Saturday, we're going to crack on with all the questions that you've posted. So please don't be disheartened. If there's anything very urgent or pressing, I'm putting our email address in the chat box. Just give us a quick call, and then I'm sure we can pass on your details to, Mr. Asumu.
Just a quick question. I've just been seeing the questions flashing through the comment box very briefly, and I note that some of them have been addressed privately to me. Now, I haven't been able to look at any of the questions for obvious reasons, but after I log off, will those questions be gone? Because I'd hate for anybody to...
I'm saving that, so I will send you the questions, as soon as we come off, so that next Saturday, if it's okay with everyone, we start with, Doc answering all the questions that, you've asked today.
Okay. And if anybody has sent me a question to me privately, please send it to Charles as well, so that we don't miss out if it somehow has come to just me.
Okay, so thanks everyone for joining us. It's been one of the most attended sessions we've ever had. And we're looking forward to seeing you next, Saturday, same time. But also on Tuesday, we have a physical activity and nutrition session between 6:30 and 7:30. And then, next Friday, we have a community meeting, between 1 and 3 o'clock, where we hear about some of the good work being done by Black-led organizations right across Greater Manchester. And we would also have someone from Manchester Foundation Trust, or, they look after Withenshaw Hospital, MRI, the eye, the dentistry, and even now North Manchester General Hospital. We're going to have Benita Kane coming on. She's, a respiratory consultant, sharing with us. And then we're going to have, Mr. Asumu back on, Saturday morning. So we're really grateful for your time. We're grateful for your offer of private contact and speaking to people. And we look forward to having you back next Saturday. So till then, enjoy the rest of your weekend, everyone.
Thanks for having me. Thank you, Charles. Thank you.
Thank you, Doctor. Bye.
Thank you. You're welcome.
Thank you.
Thank you. Bye.
Bye.
Thank you. Thank you.
So today's session is available on YouTube. You can visit our website as well for a lot of other activities happening. But Doc, we're really grateful. We'll have you back next Saturday. Thank you.
Thanks a lot, Charles. Thanks for
Thank
the platform.
you.
Okay.
Thank you.
Thank you.
Bye.
Thank you, Doctor.
You're welcome.